right, hello, health heads. Welcome and thank you for checking into this dose of the Healthcare Uprising. I'm your producer in the back, Jeremy Carr, here with your host in the front row, Heather Pierce. So let's tell them what's on the agenda for today, Heather.
Today, we're chatting with Lyle Miodaszewski, who is the president and co-founder of Perfecting Peds. Peds as in pediatrics.
PED.
PEDS. Okay. It's a mission-driven pediatric pharmacy and care coordination organization dedicated to improving outcomes for medically complex and high-risk children. This one really hit home for me because I've got some people in my life who categorize as medically complex and high risk. So really, really love what they're doing. He is a registered nurse with over 20 years of experience in diverse healthcare capacities. Lyle has led teams across clinical, operational, and strategic domains, but his deep understanding of the healthcare system, combined with his commitment to innovation and patient-centered care, has positioned Perfecting Peds as a trusted partner to payers, providers, and families nationwide. He is also he is a co-founder, if I didn't mention that. So he is part of the founding team. So
cool.
Good stuff.
All right, we don't get too many episodes that focus on the kids side of healthcare, so this is a good addition to the lineup here. So without further ado, here's our conversation with Lyle from Perfecting Peds.
Hi, and welcome to the Healthcare Uprising podcast. Today we have Lyle, the president of Perfecting Peds. Pediatrics.
That's right.
We'll say the long form because we want to make sure that comes out right. So, Lyle, thank you so much for joining us today. Excited to have you on.
Yeah, thanks for having me. I'm super excited to chat with you.
Great. So let's jump in. And first, we always like to ask, give us a little bit of background about your experience, kind of what brought you to this space in addressing pediatric medication management. And then we'll kind of go from there and see where the conversation goes.
Yeah, sure. Absolutely. Me personally, I'm a registered nurse originally. Been obsessed with healthcare since I could be obsessed with a career. Spent about 10 years bedside, emergency departments, trauma rooms, cardiac cath labs, and electrophysiology. I got exposed to sales reps in the cath lab. This is where they do balloon angioplasty and stenting and really the plumbing of the heart. There's a lot of sales reps in that environment, and I kind of took to the profession. I liked the kind of money that they were making, if I'm going to be honest. I thought, geez, I think I've got good enough communication skills, and I absolutely have the patient care experience to be able to do that. And so worked through that, worked at a bunch of different companies since then, was in the Medicare Advantage space before founding Perfecting Peds. And I stumbled across this solution. Our CEO had been in kind of a proof of concept phase for a number of years. She was a pediatric clinical pharmacist, still is. Noticed that she was getting a bunch of kids into the hospital, into the pediatric ICU in the Philadelphia area, and thought, why am I just reactive? Like, my whole profession is in a hospital waiting for kids to get sick, and then we try to help. A lot of these kids are on a number of medications, and I think we could do better on the front end and maybe keep them out of the hospital. And so she had implemented what's now Perfecting Peds in a pediatric skilled nursing facility in subacute rehab. Had initial findings of that implementation, and they were profound. And I stumbled across the manuscript and her on Y Combinator. They have like kind of a match.com for founders. And so we had both entered our profiles. It's really cool. I like anytime I talk to somebody who's trying to do something different and they've got diverse experience or they have an idea, like I always send them to this because it's kind of a success story for Jenna and myself. But she had an idea and was actually already doing it. I had this set of skills. Didn't find that I was applying them well in Medicare Advantage and specifically risk adjustment. And I really just wanted to get back to kind of the care delivery side of our ecosystem. So I got a chance to read her manuscript of the initial outcomes. I messaged her and said, if these are real, I'll hop on a plane tomorrow out to New Jersey. She said they're real, and here we are.
Wow. I love that. And I was going to ask you kind of the origin story of the company too, as well, which you've kind of started sharing a little bit about that. Can you kind of expand on that a little bit more? Like, obviously, the impetus behind it. We know there's some issues there, right? That you had already shared. But and also, are you considered a founder as well, or a co-founder?
Yeah, so my equity stake in the company, I guess, makes me co-founder.
Uh-huh.
It's myself, Jenna, and then we have a huge founding team behind us at this point in just a really short period of time. But the founding story is really hers, and I'm happy to tell it. I'm going to steal her thunder a little bit though, because this is really Jenna's story. But she was at Children's Hospital of Philadelphia, a pretty well-renowned hospital, acronized as CHOP. And then went on to a hospital in Camden, New Jersey called Cooper University. And she just kept noticing the same. This is a typical story in healthcare. Like you get, and it's horrible. We say this, but like frequent flyers or frequent utilizers, high utilizers of the healthcare system, noticed they were coming many times from a few distinct facilities in the area. So a lot of people aren't going to be familiar with this because it just doesn't exist in certain geographies, but there are skilled nursing facilities for children. There's inpatient rehab centers for kids. Where I'm from originally in Michigan, we don't have any, right? And so I wasn't familiar with this care setting, but she was, and she was noticing kids coming in, and she was spending more time working on their chronic medication regimen and tuning and tweaking and correcting things that were not good on those kids. And some of it wasn't even really what they were being admitted to the hospital for. So she went to the CEO of these facilities and said, "You guys have a problem, and I don't think you realize it. And I have a question, and that's who the heck's managing the medications here?" And the answer that she got back was a little bit shocking. And for a pediatric pharmacist, like she didn't really understand, one, how limited of a resource she was, how specialized this group of people really are, and what's happening outside of acute care, outside of the hospital. And the answer to that question was they had a pharmacist that was really just kind of checking the regulatory compliance boxes and not working up the patients, right? And so she said, "I'll come in and you can pay me whatever you're paying the other person. I'm going to open the charts. I'm going to go in between all of the prescribers and the doctors and the nurses and everybody here, just like I do in the hospital. And I'm going to help fine tune these therapies and make sure that patients are getting the right, or at least the best therapy for them individually." Um, and so she contracted with them. She did the regulatory compliance checks, and she started opening the charts. And the results of that work we published about a year ago in the Journal of Pediatric Pharmacology. But in just a 9-month period, she showed that many of these kids were on medications that were unnecessary. They were left on after admissions or discharges from the hospital and shouldn't have been. They were on the profile and nobody knew why. They were on duplicative therapies. They were on therapies that were unsafe or causing harm or interacting with other drugs. And so
And
she was
probably
able
why
to
they're ending up in the ER, right?
a lot, and often mislabeled as a new diagnosis and not like the effect of the medication in an adverse drug event. So she implements this thing, deprescribes a bunch of unnecessary medications, takes these kids in this facilities are on an average of 23 meds. She took them from 23 to 20,
23?
23.
That's a lot.
That's a lot for any age. And you think about this in a kid, and then there's a caregiver aspect, and then all of these care team members surrounding this person, and 24 hours a day, 7 days a week, they have a care team surrounding them, and they still had this room for improvement. So she does this. She does it for a period of 9 months. The deprescribing is just a small chunk of really what it was. It was taking a look at the full thing and saying, is neurology talking to cardiology when they change neurology meds that affect cardiology? And does cardiology need to do anything about their meds because of this adjustment? And the answer was usually no. And so outside of the deprescribing, just the fine tuning of things, they stop admissions from the skilled nursing and subacute rehab into the hospital, which is really important to those businesses to keep patients there and not one, nobody wants a kid or any patient to get sick, but like they also want that patient to stay with them. And so she kept them from being admitted to the hospital from benchmark pre-implementing the solution to just 9 months later, they had reduced the admissions to the hospital by 44%.
That's a huge number.
Wow. 44%.
And that, equates to cost, right? Which is something we talk about a lot in the healthcare industry is, these unnecessary visits to like ER, ICU. So avoiding those, that's a big cost savings as well.
And all the drugs they
So,
don't have to take now because they were taking the wrong drugs.
And just healthier, right?
Yeah.
Well, better cared for children. And
absolutely. Like, those are the two
just to
light
be
bulbs.
clear too, Lyle, I just want to make sure that like anyone who's listening to, when we talk about these kids, that these pediatric patients, these are children with like chronic health conditions, multiple disabilities, potentially, right? So, which is hence why they're on so many of these medications.
Yeah, so in the study, absolutely some of the so children of medical complexity make up somewhere between 1% and 3% of all kids. That just means that they have multiple diseases. They're usually on some sort of technology, meaning a ventilator, a feeding tube, some sort of technology that helps them sustain life. And so in the study, yeah, these are some of the most complex of the complex. And the original hypothesis was like, I don't want to call it low-hanging fruit, but like that's who needs the help the most, right? So like the two light bulbs there were one, this reduction in utilization, and the two, exactly what you just said, Heather, is like there's a cost associated with that. And so we were charging the health plan, or I'm sorry, we were charging the facility. They were getting benefit out of it, but like this was creating a massive cost reduction for the health plans that have risk on those lives, right? The Medicaid commercial plans that those
long-term care, yeah, all that.
So it's evolved since then by way of it. But today, like as we talk about this, the idea has changed a lot. So 31% of pediatric prescriptions contain an error. It's 3 times the rate of adults, and that's a really good source. 2023 research out of the medication errors report by the US Pharmacopoeia states 31%. We think it might be higher, or like at least non-optimized prescriptions. A lot of this is rooted in something as simple and silly as the fact that pediatric medications are dosed based on weight. And if you're a parent or you've ever seen a prescription or you've taken in a child's prescription to the pharmacy, guess what's not on that? The weight. So we see, in our own kids, my kids, Jenna's kids, our CEO, like oftentimes the indication for the drug does not match up with what the dose was, and there's no check at the pharmacy. It just gets filled. It just gets filled.
So this goes beyond these special care centers and these, the chronic condition kind of stuff. Like this is all kids then, right? Like, I mean, this is generally just pediatric medicine in general. It's not just for the hardest cases, it sounds like.
Yeah, I mean, like, let's be honest, deploying a high touch clinical pharmacy service on your typically healthy kid that got bronchitis and it got really out of control, it'd probably help them. Is it scalable and doable across, 333 million of us in the country? I don't think so. The realization, though, is like there's a group in between that and up to the most extreme medical complexity you can think of that would benefit, and like the cost argument's there. And so we're slowly finding that sweet spot. We're working with health plans to look at their data, oftentimes look at their pediatric data in a way they haven't before, and pull out the same kind of kids that we're starting to get used to seeing and be like, there's one that we can help. This disease state or these drugs, it's not even the most expensive stuff. Sometimes it's the cheapest stuff that causes harm or just isn't right. And it's crazy when we go into health plans and they're like, oh, this sounds kind of like a Medicaid thing or this population or that population. And we're like, well, let's see your data. Let us show it back to you with our filters and our knowledge on it. And they're always shocked. So
Wow.
it's super prevalent. Yeah.
So, actually, this is a great opportunity to maybe share a little bit more. You've already kind of teed this up a little bit. You work with health plans. What does it look like with you guys? Like, how do you kind of show up? How do you enter into this kind of ecosystem working with the kids, the families, the providers, right? Because of these care teams. I know you and I, when we did our prep call, I shared that my nephew has multiple chronic conditions. He's not on 23 meds, but he's on a lot because he's got epilepsy, he's got CP, he's got autism, he's got braces, right? Because of the CP. And he goes to a special school and he's always at Phoenix Children's and he had brain surgery. I mean, I could just keep going on and on about all the things that he's dealt with. And I have seen from my own personal experience helping to care for him the changing of the meds for him and how you change one thing and what it does to the other. Now he's not on feeding tubes or anything like that, so it's not quite as extreme. But anyhow, I could just from talking to you, I can understand like how what you could do, the impact. But share with us kind of like how you show up, like how do you kind of get into this space and work with those families?
Yeah. So like the health plans became attractive after we were like, okay, we've got something here clinically. We think that the solution is long-term relationships with patients proactively and reactively. How the heck are we going to get to them? Again, Michigan, no facility for me to go knock on the door of. They're at home. Um, Most providers we were talking to, so we would go to a regular clinic, or like the first one we talked to was a neurology clinic in Minneapolis. And they're like, yeah, we would love this support. We get it when our patients are in the hospital. As soon as they're discharged, we don't have any help. Um, how are we going to get to them? And so the the first thing we thought was obviously like the risk bearer, the insurance company has the margin to make on any savings that we could create, but they also have a familiarity with medication management and a little bit of a different regard and a mandate to do it. So in Medicare Advantage, which is kind of the privatized market of Medicare, you get a choice when you turn 65. For people who don't know this in this country, right? You get to choose, do I want to stay on what's called fee for service, where I can go to any doctor I want, any specialist. I have a 20% copay or co-insurance with that care, but I've got kind of freedom. There's not a narrow network of providers or prior authorizations per se like there is in privatized Medicare. More than 50% of our country is now on a Medicare Advantage where it's managed by an insurance company. In Medicare, since the early 2000s, and it doesn't matter which side of that you pick, there's something called medication therapy management, or acronized as MTM.
MTM, I know that acronym.
All right. So we knew people were familiar with that. We knew that it's kind of commoditized at this point. Some people in health plans, I kind of think of it as a four-letter word. It can be good, but it's also been abused. Like there's been companies that have done it and just checked the box. It's very focused on a transactional basis with a patient. It's brief, it's drug focused. But we knew that existed. We knew that it was a regulatory mandate for Medicare beneficiaries. And so we started going to the people that manage those programs and the buyers of those programs at health plans and said, what are you guys doing for kids? You have to do this for adults. The polypharmacy exists over here in this population too. It's even more complex because of the dynamic nature of like disease progression in kids, the growth progression, and just like the off-label use of drugs in pediatrics. It's really prevalent. What are you doing for kids? And the first health plan was like, nothing. Where have you been? We've been looking for you.
Oh,
And
wow.
so that was another moment where we were like, okay, this is probably the place we need to go. We just need to like let them understand that we're not going to lower our standard of care, but we'll come in underneath the guise of any program just to get this thing going and kind of prove out that we can do this at the population health level.
That gives you an idea you're on the right track when the first people you go to with your product are like, "Where have you been our whole life?"
Yeah, that's gotta feel
Chills
good.
up the back of your
You know
spine,
you're
right?
filling a needed niche right there when that happens.
I have a question about the health plans too, to understand. I've worked in the healthcare industry for a long time, Medicaid, Medicare, commercial, right? Kind of been everywhere. Do you find that most of these pediatric patients, are they on Medicare? Are they on long-term care plans? Are they on commercial? Is it kind of like all over the place? I'm just kind of curious in terms of like where do they actually show up? Because I immediately think Medicaid long-term care plans, but I don't think that's not necessarily where they all are, right? Or the major or even maybe even the majority are.
So it kind of depends on how you segment who can use the help. If you think about the most complex of the complex, typically on CHIP Medicaid,
Hmm.
the facility residents for sure are on those types of plans.
Okay.
Again, when we started looking at this and saying, hey, the first threshold for us was any kid who's on five or more medications at a time and like their state in growth and their unique pathophysiology and their disease state, like they're an N of one in the world. Okay. Just
Hmm.
five factors on the medication side. So we set we set the threshold there. When we started going to the health plans, we anticipated all Medicaid. um, what we've received is not. So some of this is just by like where we're networked and who we knew and what health plans signed up first and their product mix or their lines of business.
Hmm.
But the other portion is that like there's tons of pediatric patients that are on 5, 10, 15 medications that are commercially insured. They're buying plans off the healthcare exchange. They're insured by self-insured employers. And so the first health plan we worked with was Medicaid, administrative services only for employer groups and commercially insured lives, which was a complete surprise to us. And
Yeah.
today our patient mix is it's the same. It's we have all of it. Whenever we go into health plan, usually someone wants to push us over to the Medicaid folks, and we're like, hey, can we just look at all your data?
Yeah. They're probably there, right? And you always find them, right?
Always.
Yeah.
And always more than they ever thought.
Okay. So like employer provided health, you're right? So like me getting my insurance through my employer, if I have a child who falls in that category, they could be on a plan like that. And you could also be on Medicaid and you could be on all the other things, right? So,
For sure. Like, okay, Heather, your nephew is one example, but another one, like the number of kids that are on multiple behavioral health medications, 3, 4 medications, they're not even considered medically complex, but they're being treated with a number of psychotropics, or
mm,
your type 1 diabetics that also have asthma. Like these are the kind of combinations, or epileptic patients who
mhm,
have, something else going on. Even when they exacerbate within that single disease state, so they get COVID on top of their epilepsy. Like there are things that have to happen and considerations that need to be made and extra labs that need to be checked that aren't the case for a typically healthy kid. And so that expands the population that we think needs the extra attention. Maybe it's not as frequent in a proactive fashion, but should we be looking for the rising risk? Should we be looking for concerning prescriptions, admissions to the hospital to say, okay, now's the time we jump in, try to see if we can do something. And maybe they're not our long-term patient, but there's probably something to be done for that kind of a kid.
mm,
And like you pointed at how every combination of drugs is a very unique, you know, effect on the person, especially since all our physiologies are different. How do you actually track all this? Like, do you guys have like an AI system set up to actually correlate all this data and keep compiling and all that sort of thing? Because it just seems like infinitely complex, this problem you're trying to solve for.
Totally, yeah, it totally is. First of all, there is no robust data set. We're running in a capitalistic healthcare society that's driven by profits, right? And very little research and development goes in on the front end goes into pharmacotherapies for kids. Very, very little. And so if you talk to anybody who prescribes in the space, a lot of it's based off experience still, and what they've seen, or single case reports, or drawing conclusions from adult studies, and then writing for off-label indications of drugs. Slowly here, we're compiling what works. We're absolutely following clinical guidelines that are set by the medical institutions. We're following the standard of care if it's been established somewhere, but the unique combinations that you just referenced, there's not a big database of those to put an LLM over the top of. We think we're going to have one, and we'll probably have a good one. We probably do right now to start putting that over, but we're recognizing the patterns, and then we're creating the clinical pathways and decision trees of, if you look like this in our experience, we should probably try, X, Y, Z next, whatever that is.
So you're doing it. You're like doing the work that maybe should have been done like that. It's like live R&D. It seems like in the actual actions and the execution of the work that you're doing with these families and these children.
And it's very individual,
Yeah.
case by case kind of process then.
Wow.
Yeah,
that's really
and that's a
complex.
subjective component of it. Like when I was talking about medication therapy management, like our first thing is to get on with a patient and say, like, hey, how are you feeling? How are you toileting? How are you sleeping? How are you eating? Tell me about this drug. Is it working for you? How is it making you feel? And it's very dialed into the exact feelings and the signs and the symptoms of that patient. So that comes by way of a subjective assessment and interviewing somebody just like this on a Zoom telehealth call. It comes from gathering clinical data from anywhere we can grab it. We're getting better at that, as slow as the progression's been with clinical data and electronic health records and stuff. But to answer your question a little bit more directly, we shopped for some sort of software to do this. Because of the nuances of pediatrics, we couldn't find it. We looked at the medication therapy management platforms that are out there. We looked at the EHRs that are in hospitals and doctors' offices today. We looked at care management platforms, and nothing really fit this weird thing we're doing. And so we started to build it on our own. We've been doing that since October of last year at a very fast pace. And it's all being done internally today.
Wow. That's crazy. Talk about like filling a gap, right? And a need that is
Building from scratch on this one.
Yeah, sometimes you just have to build it yourself. And so kind of staying in that, obviously you're getting some clinical data by literally meeting with these families, getting some of the data that you're seeing from these health plans. Can you share so you're into the door at the health plans, they're giving you maybe the claims data, whatever they're letting you see. You're identifying these we'll say opportunities, right? Patients essentially that you're like, okay, they need our help. They need our help. Now we've got this list of people. What happens next? Like, how do you get in touch with these people? How do you get connected with them? And then how do you help them? And like, what are some like the immediate benefits that they see, and how quickly does that happen?
These are awesome questions. Okay. I wish health plans
A
would
lot
ask
of
us.
questions. I'm sorry. I just like threw like three at you here.
I wrote one down because I don't want to forget the last one, because I think that's the most important question. But
Agreed.
so yeah, you kind of laid it out right, how we get to a patient list. We agree with the health plan. Here's our list of people. We're going to go and we're going to try to get them engaged. I think one of the values is like, there's a lot of money in innovation in software and healthcare and digital solutions that somebody else needs to go and do it. And so that's a hard sale. That's hard to actually get outcomes on. Everybody's already overburdened. So one of the other things we say is like, yeah, we'll do the identification with you. Like, this is a process. A lot of companies, they're making their entire revenue stream just off doing that. So we do that as a sales activity. We don't charge for it, to kind of prove like, hey, we're in this with you. We're going to look and show you what we think we can do before we ever do anything or charge you. And if we do this, you can't charge the patient. They have to be able to be enrolled into it. If they're we determine who's eligible, but no copays, no coinsurance, no deductible, no out-of-pocket maximum, no
Totally
bills,
free.
no balance billing, none of it, because it's already a hard enough sale. So get the panel, and then we just start cold calling. Typically, moms and dads, caretakers, foster parents, guardians, whoever is the responsible party, if they're
Mhm.
under 18 or over and they have that authority,
Mhm.
or the patient themselves. We see patients up to the age of 24, and between that age, like graduating from pediatrics to adult medicine, especially when you have medical conditions, is really kind of a tough period of life.
Mhm.
So we reach out cold. The health plan usually co-markets and co-brands some snail mail, emails. We can do
Mhm.
text. But imagine like you're the recipient of this thing. You've never heard of it. It takes
Is
some
this for
explaining.
real? Right?
Yeah.
Is that like the first way? I would imagine like this is too good to be true, right?
Well, it's either that or like you're a scam.
Right. This is so
Um,
typical in healthcare.
how do I
Yeah.
validate you're real? I'm not giving you any health information, right? So
Right.
it's usually one of those extremes. Like,
Hmm.
thank God you called, or this sounds good, but I'm gonna go back and call,
Hmm.
Blue Cross or whoever.
Yeah. Yeah. Is this legit? So, but
So yeah,
then they work with you.
it's cold calling, telling somebody that you have their information. They look like somebody who needs help medically, and you want to help in a way that they've probably never heard of, right? Like I can say telehealth, most people will be all right with that. But like we start talking about clinical pharmacy, if you haven't worked in a hospital, like uh, what's your definition of what a pharmacist, like their main job is dispensing meds, not making
Right.
therapy decisions.
Right. They're
Um,
not putting the care plans together or anything like that. They're just executing they're being told, right? Essentially.
Yeah, like you
Yeah,
walk
following
in with a
orders,
written
validating
prescription.
prescriptions, making sure they're safe from
Right.
like an allergy perspective or a drug to drug interaction perspective. But it kind of ends like
Yeah.
I'm sure there's more to it, and
Sure.
please don't hate on me. The hundreds of thousands of community pharmacists out there, because you're doing great work too. We're just doing
Right.
something different, right? And
Yeah.
so
It's very niche.
when I cold call, it's a sale, right? We're selling something, it's free to them. It's on behalf of their health plan. It's a benefit that their health plan probably didn't tell them about when they enrolled, but they have
Hmm.
available now. We have to reset that what their concept of pharmacy is comprehensively, and then get them to agree to meet with us the next time we have a call, and put them on video and then align them to a single pediatric pharmacist and the nurses and technicians that we have supporting that role.
Do you have your own clinical staff, like pharmacists and clinical staff that communicate with these families that essentially join those calls and help kind of understand like what are all the things that your kid's on? Uh, Okay, this is right, this is wrong, this could be better. Is it does it work kind of like that?
Exclusively.
Okay.
Yeah. So we our intent was not to become a technology company. It still isn't. We're developing the technology to be able to do the thing.
Hmm.
And for us, the thing is clinical care. It's attributing a single pharmacist that meets with them every time we see them, and a nursing team. So yeah, they're all employees here at Perfecting Peds. We have a pharmacist team, we have a nursing care management team, and we have a technician team that are all working on these patients together.
Yeah, I always like to say innovation shows up in really different ways. It can be a person, it can be a program, it can be building a relationship, and that like consultative support that you're providing that is in turn changing and impacting these people's lives, right? Because you're plugging into a system that hasn't been looking out for them. And that is an innovation. That's innovation. Innovation doesn't have to be technology. So I love that.
That's a cool definition.
Yeah, I think so. So
I can't, my brain is still lingering on that 44% reduction in ER visits or whatever it
that,
was. Like that
that
right there tells you you're doing something right.
right,
Like
right.
that's a big number,
It's so
44%.
like in it's a hard sell, right? Because it's not hard cost. The de-prescribing thing, nobody's going to argue that. If somebody's on something and then we take them off because they didn't need to be on it, and that thing cost $1, you saved $1. There's no way to predict how many times Jeremy and Heather go to the hospital, but we can we can make inference and say you for what you look like, your utilization rate is this. And based on the type of interventions that we're doing, and we do about 13 on average per patient, the cost savings of that looks like this. It was really easy to do in a facility when we knew what the admission rates were for those patients as a group before we came in. At the pop health level, we've got to convince payers to give us all their data, which we haven't done yet.
Yeah, that's the hard part. I feel your pain. I get
Yep.
it. Been there.
As much as our data is everywhere already, people really don't like giving it out willfully.
Yeah. 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 Especially, yeah, with HIPAA and
It's competitive,
privacy.
right? Like the health plans are competitive with each other.
Mhm.
Even health plans under the same franchise, you think about like Blue Cross Blue Shield, they're all
Yeah.
competing with each other. They don't necessarily they have competitive bid process on government contracts. They don't always want to give away their sauce or where they're saving and where they're not.
Yeah.
Sure.
So where the big question, the most important question, what is the immediate benefit for these folks, for these families? When you get in there and you work with them and they say, "Yeah, like I'm ready. Come on in and help us out." What do you see?
I wrote down the third question and I never answered it, did I?
I know. I want to make sure you got this is literally the reason we're here now. I think is like, how are you changing lives? Because that's what you're doing,
Yeah.
in my
Yeah.
opinion.
So the first interaction is this like pretty big assessment. We do a decent amount of work before we ever see the patient. As soon as they say, "Yep, sign me up," we're pulling in as much information as we can. So we're looking at there's a good aggregation of pharmacy data at the point of sale through a company called SureScripts. We'll start to look at what's been ordered, what's been picked up, and what's been left there. We'll connect to health information exchanges and the national networks that house lots of clinical data through what's called a QHIN. There was recent legislation passed over the last few years to make access to treatment information a little bit more easy for us providers. We leverage all of those new regulations through this QHIN and an act called TEFCA to get as much as we can beforehand. And we've got a good idea of where we might start to make adjustments based on the subjective assessment and kind of what we get from the patient before we ever meet with them. But the immediate thing, I think, for patients and parents is a resource. So when they end up in the ER that night unexpectedly, or they've got a cold, but something, they've got all these other things going on, and they're in the middle of the aisle at CVS or Walgreens, they've got somebody to reach out to and be like, "Hey, what do I do?" The person behind the counter there might be able to make some suggestions. Less than 0.5% of all pharmacists have pediatric training. If they call here, they know they're going to get an expert in whatever they have going on. But we immediately start looking at what are the indications for the drugs you're on? Does everyone know why you're on the things that you are? And if we can't get a good explanation of that from you or your providers, there's something wrong. Are your blood levels of your drugs at the point where they're actually doing something, or are they too high and toxic and we need to bring them down? And have we been monitoring for adverse reactions? Every time you bring a new drug onto the profile, this is something that like the layperson doesn't think or talk about. Like you're introducing chemicals into your body, they're interacting with your cells and the other drugs in there. And oftentimes, through the research that's been done before that drug came to market, we know that, hey, this psych med can delay some of the conduction in the heart. When's the last time we looked at an EKG and made sure that there's nothing bad happening from what we're doing that's worse than just dealing with the issue or using a different therapy instead of this one? So those are just a couple examples of what we'll take a look at right off the bat. But it's comprehensive medication management. We're comprehensive right from the start.
Wow. And like, what's their reaction to these folks that actually end up working with you? Are they just like, thank you, where have you been all my life? Or I've got somebody I can depend on, and it sounds like they can reach out to you pretty much anytime. Is that like a 24/7 kind of call us when you need us sort of thing?
We're not at 24/7 yet. I think
Okay.
we will be. We'll be there soon. But any way they want to get a hold of us, they can
Hmm.
call, email, text, all compliant and
Hmm.
protected. Um, I'm sorry, the first part of your question.
But what has been the reaction, just in
Oh,
general, from the people that you're serving and working with, these families?
it's been overwhelming to like see it. I'm really fortunate. Like to date, my kids are generally healthy. Like we've got some allergies and whatnot, but like it's been profound. Google us. Take a look at our Google reviews. Some of them, I mean, I'll cry when I read them. I don't want to pull them up right now. But it seems like it's a breath of fresh air. It seems like we've got a lot of time compared to, if you go into your primary care, they're really on a fixed schedule and
Hmm.
payment. They don't get to negotiate typically, especially in pediatrics with health plans on how much they're paid. So they've got a certain amount of time that they can spend with a given patient. We have the luxury of being able to sit there the first time we meet them for an hour, put a bunch of work on the front end of it, put nurses on the back end of it, and then meet them again the next month to carry that care plan forward, and then the next month and the next month for extended periods of time. And so we can listen, we can spend a lot more time listening. Um, and I think when people want to be heard, the longer we hear them, the more of a picture we can get, and then we can start to make better adjustments or at least recommendations to make those adjustments. I think, I'm a little biased in my response to this question, but I think we're providing a pretty decent value back and it's recognized. And the only objective way to like prove that is in retention. So very few patients unenroll from the service. Very few. It's like there's
Hmm.
churn in eligibility because of a health plan, but
Sure.
I can count on one hand how many patients have, after they've had just one visit, have not come back and continued on service.
Wow.
Oh,
I mean, who doesn't want help? And sometimes it's like you don't know what you need until you have it. And then when you have it, you don't want to lose it. And healthcare is complex. And then you're dealing with these very fragile uh, scenarios, right? And that's a scary place to be.
I mean,
I,
the
you know,
the 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 parents of the kids that we're working with, if the kid is, even if they're a few years old, they've been through a lot.
hmm.
They're typically reluctant to let somebody new or something new onto the care team, right? And so in these initial outreach calls, we get a lot of objections. Like, hey, we've got everything under control. I've been doing this for 12 years with my son, right? Like, I don't
Hmm.
need this. I've got it. Oftentimes we'll have to say something like, will you just give us a shot? Can you show up on video for 5 minutes? And if you don't think that it's going to provide anything for you, go ahead and hang up. Like, you don't have to do this. It's your health plan. This isn't a check for prior authorizations with your health plan. Like, we're going to work on your behalf and really just try to help you clinically. If you don't find that, then you don't have to come back. And a lot of times that works. Um, and we had one mom who was like, "You've got 15 minutes to impress me or I'm hanging up." Like said that to the
All
pharmacist,
right,
right?
then.
And
You're
she
like,
was
all
like,
right,
"Challenge
hold on.
accepted."
yeah.
Let's go. Did she sign up with you guys? And
She did, and then she brought her other two kids, and then she ended up working here.
oh,
Wow. There you go.
well, if that isn't a success story,
There you go.
as a marketer, I'm like, I would use that.
We
Uh,
should talk after we stop the podcast.
We should.
so I like to look at the big picture of things a lot. I'm a philosopher by nature. So I have a big picture question for you. I know you
Uh-oh.
said you don't have any intention of becoming a full-on tech company, but with what you do, if you compile all of these relationships of all these different drugs being taken by these different people with these different conditions, ultimately over time, I mean, you could, is that a database that could actually like lead to, okay, you're, you know, this gender and this age, and you have these underlying conditions, you need these meds. and like actually streamline it to the point where you could almost, it's a plug and play, uh, medicine situation where you really can just like, this is my physiology, this is my problems, what do I take? And it will have that information. Do you see that as a possibility, or is it just too complex because of the individual actual like physiologies, like the patient themselves are just too different?
This is like predictive modeling is what is sticking out in my head.
Yeah. Like, is that a potential for this that you see
For sure.
future long term?
I mean, given the way that we're doing this remotely and then across diverse geographies and patient populations, like I anticipate we will have probably the largest aggregation of rare disease data in pediatric lives at some point, right? Like there's really long-standing institutions in this country, Children's National in DC and all over, right? They've got a lot of information. The way that we're gathering it, the way that it's related to pharmacotherapies is probably unique. I anticipate that for sure. If nothing else, like one of the audacious goals is we want to validate prescriptions at the point of sale and the point of dispensing because it's not being done today in a way that we think is the best way that could be done. And so I think some of that plays into it. Like there's got to be a database of historical outcomes and to infer from. So I think by accident we're building that.
Or like give it 20 years, right? Then
Yeah.
you're going to have it whether you're trying to or not at a certain point, right? As long as you just compile that data.
I think so. Yeah, we'll have to hire another guy to go sell it, but I'm really into the care delivery. But no, you're right. You're 100% right.
Cool.
Yeah. That'll
Awesome.
happen.
I
But
think.
you're care delivery first, right? That's care delivery, care consultation, right? The medication management. I mean, to have a partner, somebody that you can rely on, right? It's to provide guidance and advice and kind of decision making that I'm not gonna be in the hospital again where I might have ended up there without you.
For sure.
So
Yeah,
that's
or
good.
like
Yeah.
again, how much time does the doctor have? So I get written for the new drug ABC. Do I feel confident in that when I got home? Like, can I call somebody else to learn a little bit more, make sure it's jiving with everything else that's going on? Yeah, I think that's it.
And the real people I think of are these kids these kids who have enough problems to begin with, and then their medications actually are making it worse instead of better in some cases. Fixing that problem right there is a big deal all by itself. And that's just a little piece of what you guys are doing. So
Yeah, like our CEO tells this story. The kid that broke her was just labeled with all these diagnoses in the hospital. And without getting too dorky on it, the nephrologist, the kid had kidney stones. The kid had urinary retention, was getting catheterized for urine 6 times a day. Was labeled with kidney disease. Had some other things going on where they were using drugs to drive secretions because the kid was on a ventilator and you have a lot of secretions then, but the effects of that drug slow down the digestive system. And so he was constipated. And then they were treating that constipation with stool softeners and another bowel regimen and a bunch of this stuff. And I'm doing it a really bad job at giving it clinical justice, but like a bunch of this stuff was by way of that. It was
one thing causes another that you have to medicate, and then you've got
medicating the med
side effects from one drug, and right.
Yeah.
So like I've seen that with my nephew. Yeah,
the kid was on a drug for 7 years that was prescribed 7 years previously. No one really caught that. They pulled him off the drug. It wasn't even necessary anymore, and like spontaneously urinating, not being catheterized, pulled off other medications, and like totally just the urine part alone, like
yeah,
like that is profound.
Wow,
that's huge. To not have to be hooked up to a catheter, like the freedom that gives somebody.
It was all
because of the meds they were. It wasn't a disease. Like it was
the poor kid could have been off that catheter for probably years.
Yeah.
That breaks.
And this was like, Heather, this wasn't a catheter that stayed. It wasn't an indwelling catheter. Like he was getting tortured every day, like straight catheterized
a dozen times a day.
Sorry with the hand gesture, but that just it'll break your heart thinking about that.
It does. Yeah. That's rough. That's rough. That poor kid. Ugh.
I think that's why
Thank,
we're I think that's why we're here though. That
yeah.
happened.
There you
He was
go.
like, "Oh my gosh, this is like I got to do something
Yeah.
about this." So
Yeah.
that's the cool part.
Okay, so anyone listening right now, I'm going to say this, who has a child or knows somebody who has a child that is on multiple medications, has multiple chronic conditions, has multiple disabilities, you need to call these guys or find
Yeah.
out if you can, if you're eligible through your health plan. Like, go right now. Um,
Yeah, please do.
you're like, please, come on, bring it on. We want to help people and change lives. So this is actually I've gotten really good at these segues, Jeremy. This is how I start to end and wind down the show without saying that that's what we're doing. But really great. This is a really great note to
That
end
was
on.
very meta moment right there.
Thank
Very
you.
meta.
Very. I know. I'm really good at this. I'm telling you, I was made for this.
That's all you gotta do is tell yourself.
Yeah, exactly. I feel good about this work. But seriously, run to your health plan and find out if perfecting peds is with your health plan. And if not, like go to your website, right? So
Yeah.
with that, like kind of what's next? How do we find you? How does somebody get to find out if they are eligible through their health plan? Give us all the ways to locate you online and find out
Yep.
what's for
If
you
you're
next.
in Minnesota, New York, New Jersey, Pennsylvania, Florida, South Carolina, you can check with your health plan. There's more health plans coming on board here soon.
Yeah.
We're
Should we
really
line
east
it
of the
up?
Mississippi today. We're trying to find somewhere to cross that river.
Yep.
But if not, go to your health plan and ask them for the benefit. We got contracted with a health plan in Pennsylvania because a parent went and said, "I've been paying for this out of pocket, and I want you to cover it." And they called us, and they did.
Yeah.
And it provided the benefit for thousands of others after that one parent called. Otherwise, they can go to our website and we can enroll them directly. And we pretty much do that at cost if they pay private.
Okay, so that is an option.
Is it just perfectingpeds.com or
Perfect. Yeah, perfectingpeds.com.
Amazing.
we'll put it in the show notes as well. They'll be able to, you can just go click on it in the show notes if you want.
Yeah, awesome. And I think too, just one thing I want to say, and this comes up a lot, and this is, I think, just an important part of healthcare is that we have to advocate for ourselves and our loved ones that we care for. Um, not, these the doctors and the providers and the good nurses of the universe, and there's so many of them out there. They are stretched thin, they are overburdened. They can't give each one of us probably the dedicated attention that they want to. But we have to be our best advocates, and so go fight.
Yeah.
And if you don't say anything, it won't happen. So, we've got to use our
Yeah.
voices.
If you're in a
Squeaky wheel gets
state,
the grease. One of my favorite sayings.
Say that again.
I said the squeaky wheel gets the grease.
yeah,
Yes,
there
it
you go.
does.
But yeah, if you're in a state that he did not say this is available in yet, start making phone calls.
Yep.
Because like you just said about Pennsylvania, you got a couple people from that state calling and poking at them to be like,
Hmm.
hey, get on this thing now. There you go. Soon you'll be
Surprisingly,
everywhere.
it works.
Yep. So that's our action item for the day.
You know,
If you're listening.
I feel some social media posts coming from Heather on that point.
Oh
All
yeah. Yeah,
right.
for sure. Well, Lyle, this has been amazing. I love what you're doing. This hits close to home for me. Being I'm the legal guardian of my niece Shannon in New Jersey, who I know I mentioned to you, who's in a really wonderful program there. And then of course my nephew, who I play a very big role in his life as well. Not quite as um, extreme probably as some of the families that you do help, but definitely pretty close and probably falls into those categories every once in a while. And I could just see where this would be a godsend to have to have you at our side, their side, everyone's side, who's dealing with this.
Yeah,
So
some Arizona
Thanks for doing what
people
you
need to
do.
make some phone calls.
yeah, yeah, yeah. Get to Arizona. Yep, Arizona.
We'll get you to Arizona real quick.
Yeah. So with that, thank you so much for coming on and sharing your story and what you're doing to just make your impact in that one little part of our healthcare universe. So
Yeah, great work.
Thanks for having me. I appreciate it. Thanks for giving me the time.
And there you go, our conversation with Lyle from Perfecting Peds. Very cool stuff. Very cool. But I'm going to let you take it up here first, Heather. What's our main takeaways there?
well, I think about this a little bit like how this comes up on the show quite a bit. Women's health issues have been largely ignored, and now there's a lot of technology and companies that are solving for it. What I didn't realize is how much pediatric medication management for like complex, kids with complex needs, high risk, all the things had been so underserved, unaddressed, like huge, huge gap that they're solving for.
Yeah.
Very niche, right? But when you talk about the the smallest percentage of people, of patients, always have the highest percentage of cost. And so that is where typically, a lot of focus is put, but there was nobody focusing on this. And so they're doing it, and it's just been a huge gap. So I think it's just really cool to see them kind of plugging themselves into that space, and getting to work with these very vulnerable, fragile children and their families to do something that no one's ever done for them before, and that the health plans are like, "Where have you been?"
Yeah.
So,
Right. And it's like such an obvious need that nobody was taking the time to take care of. And
mhm.
I mean, he told us that one story, but that kid, just take him off that one med.
Ah,
And
so horrible.
years of suffering could have been avoided if they had just taken him off that one medicine at the right time and
Yeah,
not left him on it for years needlessly,
yeah.
causing all those problems. It's such a sad thing that,
Hmm.
you know, that's just allowed to happen because it's literally just lack of attention to the problem.
Right,
So
right.
it's awesome that these guys stepped up and are like, we're going to be the ones to pay attention to this because these kids need help.
Hmm. Yeah, I loved how almost emotional he was about it too.
Yeah.
That just shows you how just you know how committed, how dedicated they are. This is something that's really personal
Yeah.
to the perfecting peds te peds team, everybody, the founders, their clinical teams, and not to mention, like, when you have a lot of like issues, like, and this comes up again like many different episodes, like people with chronic conditions, people with comorbidities, people with whatever, like cancer, like it is a scary, scary thing, whether it is like a short-term thing or a long-term thing or forever thing. To have somebody that you can rely on, like a guide, a consultant, somebody who you can trust to
Mhm.
walk you through these parts of your healthcare journey and your these systems that are so overwhelming, and you don't know because you're not a doctor, right? I
Yeah.
mean, to have that type of support is it's a gift, and sometimes people don't know that they need it until they have it,
Yeah. There you go. You don't know
so
what's missing until you find it. Yeah.
yeah, so I love that part
I
too.
I actually, my favorite part was that they're very specifically not looking to be a tech company.
Yes.
They're very patient oriented. They're a medicine company. They are not a tech company.
Hmm.
But long term, the tech database they could build off of what they're doing with the medicines
Yep.
could be a very important piece of medical tech in the future realms
Yep. Yep.
because of those correlations between the different conditions, the different sets of medicines, the way all these medicines interact with each other in different physiologies and whatnot.
Yep.
And it's going to take a lot of data and some pretty serious AI software, right? And probably to really utilize it that way. But he was like, yeah,
Hmm.
I mean, it's going to happen inherently as long as they keep track of all their data.
Innovation shows up in lots of different ways.
Yeah.
So,
And I feel so much better about AI since we started this podcast. I don't feel like it's going to destroy us anymore. It's just a tool that if you use it right could be amazing,
yeah, can
do
change life.
amazing things for all of us early in the end.
Yeah.
But yeah, okay. So
Like that.
yeah, there you go. If you like what you hear, if you want to keep track of all the new stuff we're going to be talking about in the future, make sure to hit the all those happy little fun buttons, the likes and subscribes, the share with a friend, hit that auto download. You'll never miss a beat. We are on all the major listening platforms. We are on YouTube if you want to see us on video. We are also on Patreon video stylely, where you can support the Uprising for as little as $1 a month. We're going to need some money eventually on this. It's not why we're here, but it would help. So we would much appreciate anything you could throw our way. I don't know, where else are we, Heather?
You can find us online at healthcareuprising.com, as well as all the social media platforms like Blue Sky, LinkedIn, Instagram, and Facebook. We post out there a lot when our episodes drop and share a lot of our past guests and future guests posts, especially on LinkedIn. So lots of good happening out there. So we'll keep you updated if you're into that. So let's see what else. I'm blanking. I'm looking for people. I'm looking for people.
I'm on the podcast.
Give me a call. Shoot us an email. Are you a founder? Are you working for a company that's doing something innovative? Are you a person with the human story? Have you had some crazy healthcare story that you want to come on and share? Give us a shout at our email at healthcareuprising@gmail.com and reach out. And I'd love to speak with you and see about having you come on the show and share your story. So always looking for those stories. So
and the personal stories get to be bonus episodes, which make them even better.
Yep, that is
on Fridays.
Yep.
Mm-hmm.
So bring it on. Give us a call or email. Other than that, I think that's our dose of healthcare for the day. So with that, keep looking for the good in the world. Sometimes that's where you least expect it.
This has been a Shut Up production.
Shut up!